Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Now, how the patient enters into the disease matters. So if you're pes planus or pes cavus, that makes a difference as to where your ulcers will be predictably involved. So in order to offload these patients and to have better forefoot health, we can understand how to read our x-rays and how to understand what we're looking for to avoid some of the predictable consequences of what happens with motor denervation. So in a patient who has pes planus, who has motor denervation, they're going to be much quicker to the level of the plantar surface of the foot and cause an ulcer much quicker than someone on the medial side who's a cavus person. So there are differences in the angles, and we're going to go over all of that so we can help to understand the biomechanical differences that we need to offload to improve our patients' forefoot health. And you can see that, most people can see that in a cavus foot, that you have such a large ground reactive force along one single point, perhaps on the calcaneus. It's not spread over a larger area. That might give you an early presentation of an ulcer at that location. Same thing for the first. There might be a very hard toe off, so that the increased pressure that the hallux MTP joint feels may cause the soft tissues to wear out and break down much more easily. And of course, we know that the hammer toes that occur when the plantar capsules wear out, this can also cause an abrasion in the shoe, and that may cause this early soft tissue ulcer, and then of course osteomyelitis at the PIP joint. And in Charcot, again, we're looking for that dislocation debris, those 6 Ds, the disorganization, the destruction, the density, and the distended joint. And in this case, we see this patient presented with an acute neuropathic fracture fragmentation. The talus has fragmented along, and the naviculus is all fragmented here. We see the lateral naviculus still in place. We can also notice that dorsal subluxation that we're seeing here of that talonavicular relative to the remaining portion of the foot, which is plantar, of approximately 4 or 5 millimeters here. In Charcot neuroarthropathy, of course, this is a more coalescent phase where we are seeing that the bones have already fractured. They have this valgus angulation and increased callus formation. Notice how the patient has supinated and stacked their metatarsals when we're looking at the lateral film, and has this dorsal subluxation chronically at the talonavicular articulation. So this chronic neuropathic osteoarthropathy. Are you ready to take your podiatric imaging skills to new heights? Check us out at radpodsquad.com. Explore our online learning community, and don't forget to like and subscribe to our YouTube channel for more enriching content.